In this video, we will discuss about beta blocker on ischemic heart disease. The most common cause of ischemic heart disease is atherosclerosis plaque on coronary artery. It blocks the blood supply to certain heart tissue area. The symptoms of ischemic heart disease, such as chest pain or angina, occurs when there is an imbalance between oxygen demand and supply in the heart tissue. Usually, the heart can adapt its blood supply to its own need by vasodilatation or autoregulation, unless the vessel walls are damaged or cannot relax. The reduced blood supply may be due to partial obstruction by atherosclerosis or spasm in the coronary arteries. When the supply and demand for oxygen are marginally balanced, an increase in cardiac demand with any physical or emotional exertion can cause a relative deficit of oxygen to the myocardium. Basically, treatment for ischemic heart can be divided into two ways. The first is increase the oxygen supply by dilating the coronary artery or prevent further occlusion of coronary artery. For example, by giving nitrate or aspirin or clopidogrel. The second way is reduce the oxygen demand by decrease the heart activity. For example, by taking rest or by giving beta blockers, which is the highlight of our discussion. Beta blockers are first-line therapy in the control of symptoms in patients with chronic stable angina, particularly effort-induced angina. Beta blockers act by antagonizing the physiologic effect of catecholamine, norepinephrine, and epinephrine on beta receptors. There are three distinct types of beta receptors. The first is beta-1 receptors, which are found primarily in heart muscle. Activation of these receptors result in increase in heart rate, contractility, and atrioventricular conduction, and also a decrease in atrioventricular node refractoriness. The second receptors is beta-2 receptors, which are present in the heart muscle but are more prominent in the bronchial and peripheral vascular smooth muscle. Activation of these receptors result in the vasodilatation and bronchodilation. The third is beta-2 receptors, which are found in adipose tissue and the heart. Activation of these receptors may mediate catecholamine-induced thermogenesis and may reduce cardiac contractility. Beta blockers' effect on ischemic heart are mediated by a reduction in myocardial oxygen demand. Myocardial oxygen demand varies directly with heart rate, contractility, and left ventricular wall stress, each of which is diminished by beta blockade. The decline in heart rate is determined both by the degree to which the heart rate is sympathetically activated, as with exercise or stress, and to the properties of the beta blockers, which are cardioselectivity, intrinsic sympathomimetic activity or ISA, and alpha-adrenergic blocking activity. Let's talk about those properties one by one. The first is cardioselectivity. Cardioselectivity refers to the ability of a drug to preferentially block the beta-1 receptors. Non-selective beta blockers have equal affinity for the beta-1 and beta-2 receptors, while cardioselective agent will primarily inhibit the beta-1 receptors. Cardioselectivity is a relative property, and substantial beta-2 receptor blockade can also occur at the higher dose that are often required to treat angina. Intrinsic sympathomimetic activity, or ISA, is the second property of beta blocker. It's also called as partial agonist activity, providing low-grade beta stimulation at rest, but acting as typical beta blockers when sympathetic activity is high. Beta blocker with ISA activity is pindolol and acebudolol. The third property of beta blocker is alpha adrenergic blocking activity. They block both beta and alpha receptors. As a result, they reduce peripheral and coronary vascular resistance. They are both non-selective beta blocker without ISA. There are many beta blockers, but until now we have 3 generations of beta blocker. The first generation is non-selective and no vasodilatation effect. In this group, we have propranolol, timolol, pindolol, sotalol, and nadolol. The second generation of beta blocker is divided into 2 groups. The first is beta-1 selective without vasodilatation. In this group, we have atenolol, metoprolol, and bisoprolol. And the second group is beta-1 selective with vasodilatation. In this group, we have nebivolol and acebutolol. The third generation of beta blocker also divided into 2 groups. The first is non-selective beta blocker without vasodilatation. In this group, we have carvedilol and labetalol. And the second is selective beta blocker. And in this group, we have betaxolol. Okay, that's all our discussion about beta blocker for ischemic heart disease. Should you have any question, please don't hesitate to ask question. Thank you.